Dr. Cynthia Levy. She holds the distinguished position of Associate Professor of Clinical Medicine in the Division of Hepatology at the University of Miami Miller School of Medicine. Dr. Levy received her MD degree at the Universidade Federal do Rio de Janeiro. She then completed residency here at the University of Miami Jackson Memorial Hospital and completed gastroenterology and hepatology fellowship at Mayo Clinic in Rochester. She subsequently went to the University of Florida, where she completed her transplant hepatology fellowship, later joining their staff. She has been faculty at our institution since 2010 and now holds the position of Program Director for the Transplant Hepatology Fellowship, and he is Assistant Director for the Schiff Center for Liver Diseases. Please join me in giving a warm welcome to Dr. Cynthia Levy as she gives an excellent presentation on itching to know, medical management of pruritus and cholestatic liver disease.
Thanks, Reggie. I was told I need to use the mic for recording purposes. So good afternoon, everybody. So I chose this topic because I think it appeals to everybody in internal medicine. To some extent, you're going to get exposed to this. We'll talk about management of itching in cholestatic liver diseases using primary biliary cholangitis as our setting. Okay, so starting with a patient, Mr. UD, white Hispanic male. He was diagnosed with AMA positive primary biliary cholangitis by biopsy. He was stage 2 to 3 at the time of the biopsy. This was in 2012, and has been on ursodiol since the time of his diagnosis. And as you know, this is the standard of care for patients with PBC. He also has hypertension, osteoporosis, history of colon polyps, and GERD. And in terms of symptoms, he has been suffering with Zika symptoms, which are also very common in this disease: dry eyes, dry mouth, and fatigue, but more importantly, severe pruritus, which he describes as incapacitating and has been his main issue. Just to illustrate where he lives in terms of his biochemistries, you see, this was the last visit. His bilirubin has been about 3, but the range 1.9 to 4.3. Alk-phos in the 800s, AST, ALT in the low hundreds. So that's his baseline. Over the past 7 years, he has received all these medications for itching: cholestyramine, hydroxyzine, sertraline, rifampin, naltrexone, fenofibrate, and even butorphanol. And his itching remained incapacitating. So he's willing to do anything. He really needs to try and get rid of this itching. So today I'm going to go over what medical therapies are available, what experimental therapies are available for itching. I want to mention for the gastroenterologist in the room, with this patient with a cholestatic disease, high bilirubin, and itching, we also have to rule out an obstructive process in the biliary tree. So we did do an MRCP for him. He did have a small filling defect that was followed by an ERCP, and he had an isolated biliary stricture. This is not PSC. It was a single stricture in the distal CBD. Of course, we were concerned about malignancy. We had EUS done, FNAs. Everything has been negative. Okay, so we did brushings, we did fish testing, all negative. A stent was placed at the initial ERCP, so we had the follow-up one to remove the stent. Another US was done, again negative for malignancy. We were very comfortable then that the itching was due to PBC, because even though he had this procedure with dilatation, there was no change in his symptoms, and in fact no change in his biochemistries, as I'm going to show it to you later. He had a follow-up ERCP a year later, sludge, had stones, but I will show you later. I'm going to convince you that this had no impact on his symptoms or liver test. So how common is pruritus? How much of a problem is this? This is reported in about 20% of patients with PBC at the time of diagnosis. And in a natural history study, it was noted that this number goes up to about 60% after about 10 years of having the disease. Now, the natural history of itching was studied in this report from the Mayo Clinic that was published in 2003. And there has been only one other study that is just published in Clinical Gastroenterology this month from the UK. So this is the only one from the US. And you can see of patients who have itching, the majority will report that as being mild. Right? Some will have moderate, and it's rare that they will have really, like our patients, severe intractable itching, 4%. In the UK database, they reported 10, 11% as the severe intractable itching. Now, in this study, UDCA did not impact pruritus, and the itching correlated with Mayo risk score as well as the levels of alkaline phosphatase. This has not been reported in other studies. This was the first time. Okay. I thought I would show you this meta-analysis briefly because a lot of people think that ursodiol can treat itching in PBC, and it really doesn't. So in this meta-analysis, as you can see, there was no benefit of UDCA on itching. Itching has no correlation with disease stage, at least this is the traditional teaching. It's more common in the extremities, palms and soles, although it can be generalized. It's exacerbated by heat and pressure, and it has been shown very clearly to have a diurnal variation. Your patients will tell you clearly that it's worse at night. Okay, this was shown in the study by Nora Bergazzo when she was at the NYU. Now, the study of itching is not witchcraft. There are objective ways to assess itching. The simplest one is the visual analog scale, which we can all do and make an effort to report that in our medical records. But there are also specific instruments that were developed for evaluation of itching, and they're helpful in the conduct of clinical trials, such as this one, the 5D itch. It has 5 domains and evaluates duration, degree, direction, disability, and distribution of itching, so we can evaluate over time if there has been a change. In addition, there are well-validated quality of life questionnaires in PBC. This is called the PBC-40. And in that questionnaire, there is an itching domain that is also used in clinical trials to assess response of itching. We were interested in looking at how clinicians report itching, how much of a burden is this problem. So there is a study called Target PBC. This is a real-world observational cohort of patients with PBC in the United States. Currently, we have 35 sites active, over 500 patients enrolled. And at the time they sign consent, they are asked to, if they want to, in addition to having their medical records reviewed, if they're willing to fill out PROs, patient-reported outcomes. So 293 patients consented to receiving these PROs, and 94 completed that. 94, so a third may look like not enough, but in fact, for this type of study with PROs, it's actually quite a good response rate. And what we found and presented in the liver meeting was that we suck. Clinician assessment of itching is really poor. It does not correlate with what the patient is reporting. So what we describe in our medical records, when we describe, which was fewer than half of the instances, does not correlate with the severity of itching that the patient is reporting. That concordance, of course, increases as the severity. So for very severe itching, it gets reported, but otherwise it really doesn't. Higher scores, no surprise, were associated with depression, anxiety, and social isolation. And in our report, serum alkaline phosphatase correlated with the severity of itching. So this needs to be further evaluated. So how does that happen? I'm not a neurologist, but I'm going to walk you through what we understand now about the pathophysiology of itching in cholestatic diseases. So pruritogenic mediators in the epidermis will be transduced into a neurosignal by activating these itch receptors. And so far, there have been several itch receptors identified, as I put in the little box there. These vanilloid receptors, G-coupled protein TGR5, there are several of those. This is called the itch neuron. So once this receptor is activated, the signal is transmitted in the C-fiber pathway through the dorsal horn of the spinal cord, where then it decussates synapses with intermediary neurons and then goes in the ascending pathway to the thalamus. Now, even though the itching pathway and the pain pathway are thought to be very different pathways, they are actually interlinked. In the nociceptive descending pathway, you can see that there are inhibitory, let me see if I make this work. It's too light, right? But there are inhibitory interneurons that when activated can actually inhibit the itching transmission, okay? So the point is there is an intersection between the nociceptive and the proreceptive pathways. In terms of cholestatic liver disease, so several pruritogenic substances have been proposed. Bioacids, of course, accumulation of bioacids, even though there is no direct correlation between the level of bioacids and the intensity of itching, they can activate, of course, their primary receptor is the farnesoid X receptor, or FXR, but they also activate TGR5, which is an itching receptor. Serotonin activates the vanilloid receptor 4, endogenous opioids, and in cholestatic disease, in particular in PBC, there is an increased tone of endogenous opioids. So there are two types of receptors that matter here, the mu receptors and the kappa receptors. The mu receptors cause itching. The kappa receptors, when activated, will actually inhibit itching. And more recently, lysophosphatidic acid has been described as being associated with itching. It's very difficult to measure LPA, but it's easy to measure autotaxin, which is the enzyme that converts LPA. And LPA activates the vanilloid receptor 1, which is also an itch neuron. Okay, so that is what is involved, or thought to be involved in the pathogenesis of itching in PBC. So how do we manage it? This is the stepwise approach that is endorsed by our society. We start with general advice, because as I mentioned, most patients will have very mild itching that may not even need medication therapy. So you just have to talk to your patient, identify their needs. What type of general advice do we recommend? Well, they should use loose clothes, prefer cool environments, use moisturizer, trim their nails, avoid hot showers. Okay. But if the patients determine that pruritus is interfering with their lifestyle and they need to be on therapy, the first line is cholestyramine. I will show you another table with the dosing. And second-line agents are rifampin, which is an FXR agonist and also has been shown to decrease the levels of autotaxin. Naltrexone and sertraline. Okay? And then I'm going to focus today on the other treatments, so some experimental or off-label approaches. And finally, I'm not going to discuss this, but you should know liver transplantation is the last resource. So for patients who are transplant candidates, PBC I'm talking about, and who have intractable itching, they have failed all the other steps, we can refer them for liver transplantation. And indeed, the first day after transplant, they're itching-free. So those are the recommended doses that we use. For cholestyramine, we started at 4 grams, so one packet, usually at bedtime. Can go up to 4 packets a day. It's the safest drug. There are some posology issues because there are interactions with other drugs, so we have to make sure this is administered 1 hour before or 3 to 4 hours after other medications. Cholestyramine has been used. Rifampin, as I mentioned, we start with 150 milligrams daily, go up to 600. But we have to know there are many side effects associated with rifampin. There are several DDIs, drug-drug interactions reported, so may not be able to use in every patient. And there is a 5% risk of hepatotoxicity that we should know about. Naltrexone, we start at 12.5 or 25 milligrams daily and advance the dose. And sertraline has been studied in only one uncontrolled study, and it helped about 50 to 70% of the patients in that study. And those were patients who had failed cholestyramine. All right, so now let's focus on these other treatments that are sometimes used to rescue patients like Mr. UD. Fibrates. Fibrates are PPAR agonists. In the United States, the one we use is fenofibrate. In Europe, North America, Canada, South America, Japan, there is bezafibrate, which is a pan-PPAR agonist. And I have to tell you that the fibrates have been now studied for the treatment of PBC as second-line therapy. Okay, so they lower alkaline phosphatase. They're still under evaluation. They're considered off-label for that purpose. But in those studies, the investigators also found that itching improved. So this is a Spanish study with 48 patients, of whom 26 had significant itching at baseline. So the VAS scale score, the median VAS was 4.4 at baseline, and it dropped to 0.8 with bezafibrate. So significant improvement in itching. With fenofibrate, which is the drug we have here, there are only anecdotal reports so far. Nasobiliary drainage has been studied in rare cases. So this is a retrospective study, 27 patients from 5 centers, of whom 12 only had PBC. There was a significant drop in liver biochemistries, and all patients improved with the itching. You will see, okay, this was too fast, but there was a significant improvement in the intensity of itching. However, this is invasive, and the duration of benefit was way too short for PBC, only 13 days, different than what they observed for diseases like BRIC, benign recurrent intrahepatic cholestasis, which is not unexpected, because in BRIC you have attacks of cholestasis that last a week, 2 weeks, 3 weeks, and then when it's over, they're disease-free, or symptom-free, I should say, for about a year. But in PBC, they didn't have significant benefit. UV light therapy, that can be used. It's very time-consuming, so 3 sessions, 3 sessions a week, each session lasting about 2 hours, and they had, on average, 60 sessions total. So 12 of 13 patients improved, but who can do that for the rest of their lives, every week, 3 times a week? But there was significant improvement. So as a temporizing measure, something that we can think about. And finally, plasmapheresis. So this is the only one study that has been published with plasmapheresis from a couple of years ago now. So they had a protocol. Patients were first treated with UDCA at standard dose, and then if they had itching, the cholestyramine was added. If no response, they added rifampin, and if no response after maximal dose of rifampin, then they referred those patients for plasmapheresis. So as you can see, there were 40 patients in this study, of whom about half were cirrhotics. And very dramatic improvement in the, so NRS is equivalent to the VAS scale, very significant improvement very, very quickly after the plasmapheresis, and that lasted. So you see at 30 days, even though the itching had increased again a little bit, it was still statistically significant and clinically significant improvement from baseline. By 3 months after plasmapheresis, the itching had recurred, but again, still improved comparing to baseline. That's the only published study. How about clinical trials? This class of drugs, the ASBT blockers, so the apical sodium bioacid transporter inhibitors, you know, the bioacids are reabsorbed in the ileum to be part, again, of the intrahepatic circulation, right? In this study, 66 patients who were on URSO on stable dose and had severe itching were randomized to one of 3 arms. Either they were on placebo or one of 2 doses of maralixibat. And this was a 13-week study. As you can see, there was significant improvement in itching in all 3 arms. So it was about 25% improvement. The drug failed the primary endpoint because there was no difference from placebo. Interestingly, this other drug with similar mechanism of action, so another ASBT blocker, was studied in a different study design. Now we had 22 patients. They had a running period where everybody had placebo, and then patients were randomized into a crossover design with a follow-up on single-blind placebo. So physicians knew, but patients didn't know they were on placebo. With that design, it's a GSK drug, the intensity of itching significantly improved only on the drug treatment arm and not so much in the placebo. And that follow-up, you can see, return to baseline. So significant difference between the drug and placebo here. And when looking at the instruments I mentioned in the beginning, the PBC-40 itching domain and the 5D itch, we also saw significant improvements in red, so greater decline in the intensity of itching in treated patients comparing to placebo. Because of the success of that phase 2 pilot study, there is an ongoing larger study, which we have at the Schiff Center. We're top enrollers in the US, but if you have patients, please refer, it's still enrolling. It's a longer study, randomized controlled trial. Right? And the last drug that I wanted to mention is nalfurafine. We don't have this here. This drug is approved in Japan. It's a kappa agonist. Remember I mentioned about the opioids, that they can activate mu receptors or these kappa receptors, and when kappa is activated, there is inhibition of itching. So amazingly, this drug was approved in Japan after a 4-week trial. One study, 300 patients. This would never happen here. But anyway, the drug is approved for the treatment of itching. And I'm mentioning this because there will be a kappa agonist that will enter study in the United States, and we should be looking forward to that. So returning to our patient, I know it's counterintuitive, but you have to start on the right and look to the left. In yellow there, we have alkaline phosphatase. In red is the bilirubin. And the bottom, we have the transaminases. So just to show you how early on, he had those ERCPs for that biliary stricture, didn't touch his biochemistries, didn't touch his itching. The P represents plasmapheresis. The moment he had them, we had impressive improvement in his labs. At one point, actually, he, for the first time, normalized all his liver chemistries. But of course, they came right back up a month after the ERCP, the plasmapheresis, sorry. But more important than this, far more important, is this comment that I got from him, that he gained his life back with plasmapheresis. So he tells me that for the first month after plasmapheresis, his itching is gone. Like he functions, he's a normal person. And then gradually, that's his, of course, this is an N of 1, but I'm giving you the data behind that. And then the next couple of months after the first 30 days, the itching gradually recurs. And by 3 to 4 months, he is close to his baseline, which he reports as a 20 out of 10. His itching is very severe. But at least for a couple of months, we can give him some relief. So this is my summary slide, reminding you of the drugs we have available for the treatment of itching. I'm sure you all encountered these patients in cholestatic diseases, including, we can extrapolate that to drug-induced cholestasis and severe itching. So we have available drugs with different mechanisms of action, cholestyramine as a resin. We have the PXR agonist, Rifampin, endogenous opioid agonist. We have naltrexone, and hopefully we're going to have another kappa agonist available. We can modulate serotonin, and we can activate PPAR with fenofibrate. There are case reports with dronabinol, in case you're asking, but there has never been a clinical trial. So with that, I'm going to answer your questions. Thank you.
That was great, Cynthia. Thank you very much. We have time for a couple of questions. Maybe Dr. Martin?
Cynthia, two questions. First of all, in patients with PBC, apart from the elevation of the alkaline phosphatase, are there any other correlations with pruritus, patients with cyclic symptoms and
No. So, as I mentioned, there has been no correlation with disease stage. In fact, the only thing that is reported in textbooks is that as patients go into liver failure, they may actually improve their itching temporarily. But there is no correlation, no direct correlation. So the only available associations that we have with the alkaline phosphatase that is resurfacing now, and the Mayo Clinic study showed a correlation with Mayo Risk Score, which is a prognostic index in PBC, but that has not been reproduced yet.
The second comment, in the hepatitis C era, one of the things that was characteristic in patients with more advanced hepatitis C was pruritus. Do you have any comment on that?
Yes, that's true. So actually, several liver diseases can cause itching. The mechanism of action, the mechanism of the itching may be different from in cholestatic diseases. As in PBC, for instance, we have demonstrated this increased opioidergic tone that has not been shown in other liver diseases. So the mechanism is different. Therefore, the treatment may be different, and therefore, clinical trials now, they have to determine which indication, which liver disease we're tackling. But you're right, it's common. We end up managing, at least with cholestyramine as the first line. But I haven't seen this type of refractory itching with other liver diseases.
Is there any racial or ethnic differences in responses to or degree of pruritus seen?
Not described, but it's a great point because every single natural history study is basically Caucasian-only population. So we are very unique, and that's one of the questions that we want to answer with Target PBC. Of those 500 patients, 20% are Hispanic. And there was no, probably from our center, and there was no difference in the intensity or response to the treatments that they were getting.
Dr. Fornoni?
Thanks for the nice presentation. Triantolone is a stronger TGF5 inhibitor. Are you aware of any clinical trial going on with triantolone? Because TGF5 is one of the receptors for the virus
Yes.
together with the FXR, no?
Uh-huh.
And so
That's a great.
Repeat the question.
So the question is about triantolone, which is a TGR5 inhibitor. And I showed you that TGR5 is one of the itch receptors. So it's a great idea. No, there are no clinical trials going on with that. I'll
We
bring
have
that
5
forward.
seats down here in the front, if anybody wants to come. and I can promise you we'll have a new building if we get attendance like this at every Grand Rounds. So, thank you, Cynthia. That was wonderful.
Thank you, Dr. Levy. It is now my pleasure to introduce you to our next presenter, Dr. Joseph Rosenblatt. He holds the distinguished positions of Professor of Medicine, Microbiology, and Immunology in the Division of Hematology at the University of Miami Miller School of Medicine. Dr. Rosenblatt received his MD degree at UCLA School of Medicine, where he also completed his residency and fellowship training. He held various academic positions at UCLA, including Director of Gene Therapy Program from 1992 to 1995. He subsequently went to the University of Rochester in New York, where he held various positions, including Unit Chief in the Division of Hematology Oncology and Associate Director for Clinical Research and Interim Director at the James P. Wilmot Cancer Center. He joined the Miller family in 2001 and is the Dr. William J. Harrington Chair in Hematology and Chief in the Division of Hematology. He also holds the title of Associate Director for Faculty Development at the University of Miami Miller School of Medicine and Sylvester Cancer Center. Please join me in giving a warm welcome to Dr. Joseph Rosenblatt as he gives an excellent presentation on updates in hematology.
I'm good. Okay. That was a very nice introduction. It reminded me of the day I graduated medical school, where I felt immensely proud. I asked my father, who was a 5-foot-tall Holocaust survivor, whether he was proud of me. He looked up at me and said, "Proud? What do you mean proud?" I said, "Dad, I'm graduating medical school today." He said, "Oh, good, good. You know what? Yesterday you were a putz, today you're a putz with a degree." All right, okay. Okay. I hope this talk doesn't go downhill from there. All right, okay. So it was very nice. Up until 2 days ago, I thought I had an hour for this talk. And then I saw the announcement, and it said I actually have a half an hour. And I thought that makes sense. The first speaker will summarize what to do about itching and cholestatic disease in half an hour, and I will talk about what's happened in hematology in half an hour. Yeah, okay. So I'm just going to show a couple of vignettes, things that interest me, that I think are of interest, and if you want the other 75 slides, you can come to me after the talk. And these are my disclosures. Okay, so what I'm going to talk about today, things that are close to my heart: immune approaches to hematologic malignancies and cellular therapies. I'm going to talk about what I think is going to be a very new mechanism of employing antibodies for purposes of for therapeutic purposes. And because CLL is the most prevalent malignancy, and there's been a paradigm shift in how we should treat CLL in the elderly, I'll mention that as well. And if you're good, I will show you 2 slides that will show you how to stop direct oral anticoagulants in patients with atrial fibrillation. All right, so cellular therapies. This is a schematic representation of a chimeric antigen receptor, or a CAR-T receptor. And I'll just point out the salient features. This can identify targets on the surface of tumor cells by virtue of having a single-chain antibody to direct its specificity. That is an antibody that has the variable heavy and light chain sequences linked in a single chain. You then link that to a hinge region that will embed it in the T cell or a natural killer cell membrane, and link to it 2 intracellular signaling domains: the CD3 zeta chain, which will transmit the first signal for proliferation, or signal 1, that T cells require, and which is identical to the signal transmitted through a normal T cell receptor complex. And the second is a co-stimulatory domain, which will expand that proliferation and induce effector function in the molecule rather than in the T cell that has engaged antigen. So this is what we put into T cells today in a new form of therapy. But before I point that out, I just want to point out that this is not as new as people think it is. The design that we put into people today is identical, virtually identical to the design of a chimeric antigen T cell. Is this, can people hear me? Oh, how do I turn? Okay. How do I turn this one on? Okay, good. Is identical to the design of a chimeric antigen T cell receptor that was first described by Dr. Zelig Eshar, who's shown on the left, accepting the Israel Prize from Bibi Netanyahu in 2015, and did this originally in 1989, and then with the design that we use today, first showed that you could change the specificity of a T cell by forcing it to express one of these chimeric receptors in 1993. And I first heard this in 1993 on the banks of the Dead Sea. I didn't believe it. I thought it was pie in the sky, and in fact it took 30 years for it to mature because there were other aspects of the technology that needed to be developed over time. But this is what we do today in patients, and this is now part of therapies that we see at this center. We've treated, I think, 26 patients at this center using this technology in the stem cell transplant group, and this is rapidly coming to the fore. So what do? We obtain lymphocytes from a patient who may have a refractory hematologic malignancy. Those lymphocytes are put into culture with antibody-coated beads that excite them through the T cell receptor, the CD3 complex, as well as through CD28. We then add a retrovirus that contains this receptor, the CAR T receptor, co-incubate that. The retrovirus inserts those genes by virtue of transducing, not actually infecting, because it's not an infectious particle. It can just insert the gene to the cells. And then those cells expand, and they now contain a gene that expresses this modified chimeric antigen T cell receptor. We expand those until we have millions and millions of cells. When the cells are ready, they're shipped back to us, usually in 2 to 3 weeks from the manufacturer. The patient is given chemotherapy to create space for those cells to expand, and then they're infused back into the patient. So when that happens, the patient then waits for the cells to respond to his or her malignancy. There are 2 of these entities already approved by the FDA, and a third that I'll show you that has received FDA breakthrough designation. And a lot of this goes on in the Sylvester Cancer Center on a weekly basis. One came from a company called Kite. It involves, they both target an antigen on B cells called CD19 that's expressed from the pre-B cell level all the way through up to stopping just before B cells mature into plasma cells. And one of them uses a co-stimulatory molecule called CD28. The other one, which is this one, uses another co-stimulatory molecule that acts a little bit more slowly, that can produces a little longer term expansion of T cells called 4-1BB. So over the past year and a half, there have been 3 indications for which the FDA has approved this technology. The first was based on a trial of 77 patients aged 3 to 25 with relapsed or refractory B-cell precursor ALL. That was in August of 2017. I'll show you data on what responses look like in that, but that may be a paradigm-changing technology in that disease and maybe the single most effective entity ever tested. The second is approval of a anti-CD28 of a CD28 stimulated CAR T cell construct called Yescarta. Anybody's free to say to use the non-commercial name for this, exacaptogene ciloleucel, sadistic almost. And that was approved for diffuse large B-cell lymphoma, as well as for other aggressive lymphomas such as primary mediastinal, high-grade B-cell lymphomas, or transformed lymphomas. And that was followed about a half year later by approval of the original Kymriah, which is the other CAR T-cell entity for the same indication due to slightly different clinical characteristics. So this was the first patient, a patient of mine and Dr. Lazaros Lukakis, who directed the first studies here using ZUMA-1. This patient had a refractory lymphoma that had not responded to 7 therapies. She's a 58-year-old grandmother, wonderful woman, who had pretty much given up. She'd gone through 2 experimental therapies. We gave her the CAR T cells made from her lymphocytes in December of 2015. She, after 2 weeks in which she had substantial side effects, including cytokine release syndrome, and both a dense receptive and expressive aphasia and disorientation. She emerged neurologically completely intact. The fever stopped, and a month later she was in complete remission for the first time of her life. She remained in remission until July of 2016. At that point, she had a small relapse in the liver. It was biopsy proven. It still had the target, CD19. We gave her another round, which produced a complete remission almost without side effects, and she was then transitioned to an allogeneic transplant. The reason I present that case is it had many of the hallmarks of this very unusual therapy. The first is that after you give these cells, they're kind of like giving an immunologic bomb with unbridled proliferation and cytokines production as they encounter tumor antigen. They produce a febrile illness, which is a fairly nasty illness. It's kind of like the bad flu, occasionally associated with nausea, vomiting, diarrhea, hypoxia, occasionally requiring an ICU stay, tachycardia, clotting disorders, in rare cases, renal dysfunction, and severe headaches and confusion. But in addition to that, it can produce a very virulent neurologic syndrome of variable severity. That's usually transient. Usually some of this will come on initially with the cytokine release syndrome in the first few days, and some of this may be delayed, come on around day 5 to day 7 or so. And because the toxicity is so exotic and so difficult, we've developed specific grading systems to try and compare toxicity between these reagents. And the toxicity may range from mild impairment, inability to write properly or remember things properly, to generalized seizures, and even cerebral edema and herniation. But we do this because these are effective therapies in settings in which there are no effective therapies. So one of these, ZUMA-1, which is the trial that we did here, enrolled somewhat over 108 patients. Overall response rates were in the 80% range, of which about 58% achieved complete response. And ongoing responses then dwindled to some degree, but there clearly are plateaus in complete responders, to where at the end of the day, about 40% of patients remained in complete remission. Now we do this commercially at the Cancer Center. I should add the additional toxicity. One of the CAR T products is $450,000 just to buy the product, to infuse it. The other one, the one we have used the most here, is only $373,000 to buy the product, a real bargain at today's rate, which has led to ideas like installment plans for people who are going to receive CAR T therapy. And that's no joke, because you actually only give the therapy once and perhaps can pay for it over years. And those who saw the Wall Street Journal have seen that may be a prevalent idea in many gene therapies. But our experience with a commercial use of the CAR T is pretty much reminiscent of the experience in the original trial. So to summarize, there are 2 products for diffuse large B-cell lymphoma. Both of them have relatively high response rates. The one we've used the most here has a complete response rate of about 50 to 60%. The other one that was recently approved, about 40%, and ongoing complete responses durable with greater than 6 months, which appear to be durable, are in the neighborhood of 30% using any of these commercially available therapies. This has been a game changer, this technology, in the treatment of relapsed ALL. I'm going to show you, this is what the outlook is for adult patients. This is based on the ECOG 2993. We use this regimen quite often. And if you relapse with adult ALL, your overall outlook for 5-year survival is somewhere in the neighborhood of 7%. So when CAR T cells were tried in the setting of relapsed ALL, either pediatric young adults in the Eliana trial, or in the setting of older adults, you can see that the complete response rates, and these are in individuals, many of whom have actually failed transplant, are in the neighborhood of anywhere from 60 to 90%. There is even greater toxicity in the setting of ALL than there is, including neurotoxicity. This transiently halted some trials, but the efficacy is unmistakable. And so this is just the complete response rates as well as rates of the cytokine release syndrome and neurotoxicity. This is from the largest series done by Jay Park at Sloan Kettering, and I'll just point out that the complete remission rates in these patients who really had very little hope were somewhere in the neighborhood of 83%, and they were seen across all categories of patients, including older patients greater than 60 years, Philadelphia chromosome positive patients, and this was particularly effective if the patient had relatively low disease burden, meaning less than 5% leukemic cells in the marrow, in which case there was an excellent overall survival compared to historical controls. There are more recently, a form of chimeric antigen receptor T cells has been extensively tried in the setting of myeloma. What this targets is something called B-cell membrane antigen, which is an important receptor that's important in supporting the differentiation survival of plasma cells. This receptor is expressed on B cells from the germinal center phase all the way to the plasma cell phase, and it tends to be highly expressed on myeloma, and the more of it that you see, and we also see a soluble form called soluble BCMA that's shed, the worse the myeloma and the worse the prognosis. So this CAR T cells have been made targeting the BCMA receptor. The first phase 1 trials were reported in 2017 and have now been updated. This is an example. The responses in this disease are rapid. In the original trial, most patients had received up to 7 or more lines of myeloma therapy. One sees a precipitous decline in monoclonal light chains and monoclonal proteins, as well as improvement, as in this case, only 2 weeks after treatment on a CT PET scan. And I just want to point out in that trial was a dose escalation trial, and as they escalated doses, they saw a significant number of patients, in fact, over 95% of those in the expansion cohort of this trial at escalated dose, who either achieved a stringent complete response with complete disappearance of both protein and plasma cells, or a very good partial response with 90% disappearance of light chains or the abnormal monoclonal protein. And it didn't seem to depend very heavily on the degree of BCMA expression. As long as some of the cells expressed BCMA, there appeared to be a good target for this. This is a very versatile technology, as you can see. And I'll just give you one last example of something that will be arriving in the next year or so here, and that is there have now been receptors made that will allow receptors, T-cell, genetically engineered T-cell receptors that actually allow coupling of T-cells to any antibody, tumor-specific antibodies, and the trick that was done there was to mate the FC receptor with co-stimulatory and intracellular T-cell signaling molecules so that this FC receptor could bind any antibody. The fact that this works is still a great mystery to me, but one can imagine, and we will be starting trials using this technology in combination with antibodies such as Herceptin or cetuximab to target solid tumors, or rituximab, for example, to target hematologic malignancies. This is my grandson, Max. As you can see, he's quite athletic. He was 6 months. Okay. Let me just, I want to talk about one more very interesting technology or interesting new kid on the block that was reported from in the New England Journal by Dr. Advani of Stanford and Dr. Sonali Smith from the University of Chicago. And that is, we use antibodies primarily to evoke antibody-dependent cytotoxicity, killing by natural killer cells, or to fix complement. That's what we think we're doing with rituximab. But you can also use antibodies to provoke macrophages to become phagocytic and actually ingest tumor cells, the same way that they do other pathogens. But that has never been a successful means of targeting tumors. And the reason is that many tumors express a don't eat me signal called CD47, which is a protein that interacts with a signal regulatory protein that's an inhibitory protein on macrophages, monocytes, that prevents ingestion and phagocytosis. And in the laboratory of Dr. Irv Weissman and Dr. Advani has made an antibody, have studied an antibody that actually blocks the interaction of CD47. It's an IgG4, so it's not designed to evoke cytotoxicity, but just to block. It binds to CD47, prevents its interaction with SIRP-alpha. And when you do that in a trial that was reported in the New England Journal in 22 patients, 95% of whom were known to be refractory to rituximab, one saw responses like this. So this is a 58-year-old woman who failed 4 lines of therapy, including failure 3 months after an autologous transplant. And the combination of rituximab in order to opsonize tumor cells, and she had failed multiple rounds of rituximab, and this antibody resulted in a durable, complete remission, which was manifest within 8 weeks. This is another 56-year-old male who had failed 7 lines of therapy and a similar kind of response to this antibody. The overall response rates, even this was a small trial, was objective response in over 50% of patients, complete responses in 36, and responses were seen in diffuse large B-cell lymphoma as well as follicular lymphoma. So I think this is going to be a game changer, because I think this idea, that is, that you can opsonize a tumor cell with an antibody and then prevent the tumor cell, the effect of tumor-expressed CD47 that prevents phagocytosis, could be used in a large variety of settings, and this is just proof of the principle, which is why I think it made it into the New England Journal. The last thing I'll talk about is a shift in the treatment of CLL. CLL, as you know, is the most prevalent lymphoid malignancy, and in 2013, a drug called ibrutinib was approved. Ibrutinib was approved because it blocks signaling from the B-cell receptor. That signaling proceeds through a molecule called Bruton's tyrosine kinase. This is very effective. 2013, this was approved for mantle cell lymphoma, 2014 for CLL, 2015 for Waldenstrom's macroglobulinemia. And in CLL, its use was initially restricted to those patients who don't respond to chemotherapy, who have a p53 mutation or p53 deletion. That's the way we used it, but a lot of clinicians liked using it in older patients because it has, in general, fewer side effects than chemotherapy. So at the plenary session in ASCO this year and in the New England Journal shortly thereafter, they reported a trial in older patients aged over 65 comparing the use of standard chemoimmunotherapy, either bendamustine or rituximab, or chlorambucil and an anti-CD20 antibody called obinutuzumab, to ibrutinib. The trial's endpoint was median progression-free survival. These are some of the agents that are used. This can't be used in people over 60 very effectively, but these two are often used. And these were compared to ibrutinib or ibrutinib plus rituximab. And there were some very interesting findings in this trial, which was done in the cooperative groups. The first is that the overall response rate to ibrutinib was better than to ibrutinib, or ibrutinib and rituximab was identical, and better than that of the chemotherapy bendamustine plus rituximab. In addition, but chemotherapy is better at inducing complete responses, but they're probably not that meaningful, and most of them don't result in complete eradication of disease. The primary endpoint, though, showed that progression-free survival was far better with ibrutinib or ibrutinib and rituximab than with chemoimmunotherapy, and was particularly better in those patients who were the least likely to respond to chemoimmunotherapy, such as patients with deletions in chromosome 17 that deletes p53, or patients who have complex cytogenetics. So the conclusions of that trial are ibrutinib and ibrutinib plus rituximab is a significantly better way to treat elderly patients with CLL compared with chemoimmunotherapy. And rituximab actually did not improve progression-free survival over ibrutinib alone. That was not a big surprise because there had been other studies that suggest that. It is important to note that BTK inhibition is not totally benign. There's a high incidence of atrial fibrillation, other cardiac manifestations, and so there. And in the future, I think there'll be strategies to see whether one could induce complete eradication of disease, which would allow discontinuation of therapy. All right, I promised you the last thing. This is the last thing. Okay. You frequently will encounter patients who have apixaban, who are on apixaban or dabigatran, thrombin inhibitor, or rivaroxaban for treatment of atrial fibrillation, so the use of DOACs. Many of these will have to go to surgery. So this is a slide from the late-breaking abstracts at the American Society of Hematology that tells you exactly what to do and how to do it based on a trial of 3,600 patients conducted across 23 centers that originated at McMaster's in Canada. And basically, it shows that in patients with atrial fibrillation who have who need to be interrupted for elective surgery, depending upon the risk of the procedure, you don't need to do any testings. You can continue up to either anywhere from 2 to 4 days before surgery. You then stop, and this tells you exactly when to start so that your net risk of major bleeding is 2% or less, or arterial thrombosis 1% or less. I wanted to give you at least one practical piece of advice. Okay. Okay. All right. Thank you very much.
Joe, that was perfect. Thank you. I wonder if you could please give the reference for the last slide, so that when people fill out their evaluation, they'll be able to get the reference. Just give it to Laura, and she'll put it on.
So, I mean, this is online anyway. The slide is online. But the reference is not out yet. It's a late-breaking abstract at ASCO on the PAUSE study, P-A-U-S-E study. I actually looked for it to see whether an article had come out yet, and only the design of the trial was out from 2 years ago. The final article has not yet come out.
All right, but at least a reference to where we can find it. Thank you. For the interest of time, anyone has any questions, please come down, and we'll look forward to seeing you next week. Thank you. That was really good. Steve, do it in 30 minutes. But the point, I told you all the things I forgot. Okay. So, but you did have an article when you chose this one and this one. There's something else. It did come up. It's not who's going to pay? Shereen! Because right now, I think it's 600.